Thank you, Dr. Afra, for the introduction. These are some cases that I encountered during my practice, and it's mostly about the approach rather than the diagnosis. Case 1, this is actually when I first arrived to Saudi Arabia. Remember, Dr. Afra, you'll remember this case. A previously healthy 8-year-old girl presents with sudden frequent nosebleeds. She was in Hafr al-Batin and they couldn't even control her nosebleeds. She had a lot of FFP transfused for her, but unfortunately she still continued to have these bleeds. Otherwise, no easy bruisability, bleeding from other sites, no bleeding after tooth extraction. Family history was negative for bleeding disorders, and medication history is negative. So when she arrived in our ER, after multiple transfusions, her hemoglobin was 10. Her platelet count was normal. She always had normal platelet counts. Her PT was high, 26.9, and they couldn't, as I said, correct it with FFP. High INR, as well as high PTT, 72. Thrombin time was low to normal. Fibrinogen level was normal. Mixing studies for PT-PTT showed continued prolongation immediately and after incubation. So just briefly, a mixing study, you mix 1 part of patient plasma with 1 part of normal plasma. This is usually standardized and given to you by the company, or you can actually pool it from your donors. And after a mixing, they measure the PT and PTT immediately and see if there's correction, and that usually points towards factor deficiency. If it does not correct immediately, this is an inhibitor pattern. And then after that, they incubate 1 or 2 hours according to your lab specification at 37 degrees, and then measure PTT. We don't usually do incubation for PT. Some labs do, because a factor 7 inhibitor is very rare. So inhibitors in general, they show up in immediate. Factor 8 inhibitor can correct in immediate mixing and later prolong with incubation. So it has a slower kind of activity. So now to summarize our patient, she has prolonged PT, prolonged PTT with an inhibitor pattern. Could be a very strong lupus anticoagulant giving non-specific inhibitor pattern, so it's reacting against multiple factors. Could it be an inhibitor of a common pathway factor, factor 2, 5, and 10? And again, that's extremely rare, especially in pediatrics. Or could it be a strong inhibitor that crossed over and inhibited factors in the intrinsic and extrinsic pathway? This is the factor assays. At that point, we decided to do the common and intrinsic pathway. Factor 2 was repeated twice, very low. Factor 5, 7, and 10 within normal limits. Factor 8, 9, and 11. First, I was contacted by the lab and told they were extremely low, but on multiple dilutions, they started to increase. So they were displaying a non-specific inhibitor pattern. This is an example of inhibitor pattern. An inhibitor pattern is defined as more than 15 absolute increase in factor activity from the lowest dilution to the highest dilution. Higher dilutions should be ordered until the factor activity plateaus within 5 absolute, or until all dilutions defined in the analyzers have been performed. So you basically see in factor 8, 9, and 11, every time you dilute, there are big jumps in factor activity. So this should point you towards this non-specific inhibitor pattern. So how do you report the factor activity? You can either report it as percentage of factor activity of the highest dilution within the calibration curve, or you can use the plateau of 5 obsolete, and as long as it's within the calibration curve. So we did the lupus anticoagulant. We have the screening at the moment, DRVVT, which was positive, and the lupus anticoagulant, which is detected. A lot of recommendation do ask for confirmation by hexagonal phase. Not all hospitals do it. Another thing which is very hard to measure is prothrombin antibodies. Why am I thinking of prothrombin? Because lupus anticoagulant usually prolongs PTT and causes thrombosis. We have a bleeding patient with prolonged PTT in the presence of lupus anticoagulant, so that should lead us towards this diagnosis. Lupus anticoagulant hypoprothrombemia syndrome. As we summarize, we have a markedly low factor 2 level, a positive lupus anticoagulant. It was actually strongly positive. All other factors within normal. Non-specific inhibitor pattern was noted in the testing of 8, 9, and 11. Follow-up, she did have a family history of SLE. Her mother had multiple unexplained miscarriages. She had 6 miscarriages. So she has a history of probably some lupus anticoagulant or antiphospholipid. The patient is now at increased risk of thrombosis and bleeding. She was eventually diagnosed with SLE and after developing other SLE manifestations. So lupus anticoagulant is a misnomer because it actually causes thrombosis rather than anticoagulation. It is one of the antiphospholipid antibodies. The main ones are anticardiolipin and anti-beta-2 glycoprotein, but you can see in the figure there's a lot of other weaker antibodies. It's heterogeneous autoantibodies, predominantly IgG, and with some IgM isotypes that specifically target the phospholipid protein component of the cell membrane. And patients who have lupus anticoagulant are at risk of both arterial and venous thrombosis as well as pregnancy loss. Review of literature, these were reported only less than 100 cases, I remember, because we had a case during fellowship. The disease most commonly occurs in young adults, sometimes children, more in female, associated with autoimmune diseases. The bleeding is a frequent feature as well. Thrombosis is less common. Factor 2 is usually very low at diagnosis. Thrombotic risk will increase after treatment because you will be improving the factor 2 level. And approximately 50% present with bleeding, and it's also, as I said, associated with autoimmune diseases and can cause severe hemorrhagic complications. So do not rely on mixing studies alone, because inactivation of factor 8 by autoantibodies is time and temperature dependent. Also, this method may not detect inhibitor with complex or slow time-dependent kinetics or very low titer inhibitors present in amounts below the sensitivity limit of the method. So you can miss an inhibitor because on immediate mixing it will correct. Take home points, as I said, do not use mixing studies as standalone method to rule in or out the presence of an inhibitor. It is important to identify the inhibitor pattern while performing factor assays to avoid reporting falsely low levels in the presence of inhibitors. We have had difficulty getting to reference ranges. When do you say this PT-PTT corrects versus not correct? We looked at multiple references. I couldn't find any. I've asked the company to provide us with their recommendation. I'm still waiting for that, but this is what we use during fellowship. Prolonged PT, we do only immediate mixing, and it should correct within 2 seconds of normal range. For prolonged PTT, we do immediate and 1 hour incubation, and PTT must correct to the normal range. So this is, if you have any other thoughts, I would be happy to share or to sit with you for your experience. Case 2, 35-year-old male with chest pain and hypotension. Workup revealed a massive myocardial infarction. He reported a similar episode 1 year ago. No evidence of atherosclerotic changes. No risk factor except for occasional smoking. Not diabetic, not hypertensive. Lipid profile is normal. Family history showed several family members with thrombosis in general at different sites. No significant bleeding or thrombosis history other than the things mentioned. Medication and drugs is negative. So usually in young age with this massive MI, you would think about drug abuse, especially cocaine, but no, there was no indication of that. His CBC, totally normal, normal platelet count. Coagulation, his PT and PTT INR were all elevated. His thrombin time was elevated. His fibrinogen was below detection limit and was repeated multiple times. D-dimer is low. So mixing studies for PT and PTT showed correction immediately and after incubation. He also had a prolonged reptilase time. Thrombophilia workup, normal protein C, S, and antithrombin levels. Lupus anticoagulant was not detected. Negative autoimmune screen. Repeat fibrinogen, as I said, always below detection limit. So the diagnosis is a congenital afibrogenemia. It is 1 in a million diagnosis, very rare. You also have to rule out, when you're suspecting this kind of case, you'll have to rule out acquired deficiency or fibrinogen consumption, like DIC, bleeding, and hyperfibrinolysis. So rule out secondary causes of low fibrinogen, such as liver disease, chemotherapy, especially with L-asparginase, as well as other causes, especially hyperfibrinolysis. And I will mention now why hyperfibrinolysis is very important to detect, because we don't have the means to detect it in the laboratory. Liver cirrhosis, again, may have high levels of fibrinogen. However, it's kind of an acquired dysfibrogenemia because of abnormal synthesis. So this fibrinogen does not function properly. So when do you check for fibrinogen as a cause of thrombophilia? It's actually level 2 testing. You have to, but for me, any cases of thrombosis or bleeding, add fibrinogen. It's an essential part of the coagulation cascade. So how do you work up a fibrinogen abnormality? You'll have prolongation of PT, PTT, and thrombin time, fibrinogen concentration, which is available in most labs, as well as prolonged ruptilase time. And this is an enzymatic it's based on enzymatic activity of the snake venom. And what it does, it cleaves fibrinogen A from fibrinogen and leads to the formation of a stable fibrin clot by bypassing thrombin. It is a qualitative assay. Normal ruptilase time can suggest the presence of heparin or direct thrombin inhibitor. So to rule out heparin contamination, ruptilase time is quite helpful. Klaus assay is most commonly used to measure fibrinogen function. We don't have it here in our institute. I'm not sure if they have it in Saudi. It requires mixing of dilute patient platelet-poor plasma with a high concentration of exogenous thrombin and measures the time to clot formation using photo-optical system. Using a standard curve, the time is converted to fibrinogen concentration and reported in grams per liter. But you have to be aware that factors that reduce fibrin formation, such as heparin and DTIs, or factors that decrease light transmission, like increased bilirubin, can lead to inaccurate results. This is a functional measurement of fibrinogen. Immunological assays can measure antigenic fibrinogen concentration. It's usually through ELISA method. The clinical utility is you have to use it in conjunction with the Klaus method, and it's to differentiate between quantitative and qualitative fibrinogen disorders. So these disorders are actually rare. Only 8% of all rare bleeding disorders. It's usually mutation in fibrinogen A or B gene that result in qualitative or quantitative defects. And these defects, as I said, can be diagnosed with the Klaus assay and antigenic fibrinogen level. The clinical presentation is heterogeneous. They can present bleeding, asymptomatic, or with thrombosis like our patient. They can have, as in lupus anticoagulant, both arterial and venous thrombosis. So this is how you diagnose. If you have prolonged PT, PTT, thrombin time, and ruptilase time, and they're infinitely prolonged, and fibrinogen is not detected, this is how you diagnose a fibrinogenemia. If the PT, PTT, thrombin time, and ruptilase are variably prolonged, so they're not going together, and there's a proportional decrease in the function or immunoreactive fibrinogen, you can diagnose hypofibrinogenemia. The last one is PT, PTT, thrombin time, and ruptilase time are variably or infinitely prolonged, and you have a normal antigen with lower functional level by Klaus method. This is a diagnostic of dysfibrinogenemia. So our patient is the first category, which is quite rare. Take-home points. Fibrinogen is crucial for hemostasis. Check your fibrinogen during bleeding or thrombosis. Suspect hyperfibrinolysis, especially in patients with liver cirrhosis or trauma, and bleeding that's not responsive to supportive measures. Most laboratories do not offer thromboelastograms or ROTEM. This is a point-of-care test, usually used by anesthesiologists or maybe trauma surgeons. But if you have a patient like that, you might coordinate with the department that are responsible for the ROTEM to perform it. And you'll see an increase in maximum lysis, which is this part, of more than 15%. So always look for hyperfibrinolysis. This is our last case, and I encountered during my fellowship. 7-month-old female presenting with an abdominal mass, hematuria, anemia. Diagnostic imaging revealed an extremely large and highly vascular tumor arising from the left kidney. Biopsy is consistent with Wilms tumor. No family history of bleeding disorders, no recent medication. Her PT is 18.3 prolonged, PTT is prolonged, and platelet is normal. Her factor 8 is 14, which is quite low, factor 9 within normal limits, as well as factor 5 and 10. Her von Willebrand antigen was 28%. However, the ristocetin or von Willebrand activity was decreased, so her ratio is 0.4. We use a cutoff of 0.6. Decreased very high and high molecular weight multimers consistent with type 2 von Willebrand. So this is probably an acquired von Willebrand disease. This is the course of her treatment. She received fresh frozen plasma, humate P, which is a factor 8 and von Willebrand concentrate, as well as pure factor 8, IVIG, and she still had persistent hematuria and bleeding, but without adequate sustained and rise in factor levels. She was started on chemotherapy. Again, there is no improvement in the bleeding. Coagulopathy persisted. So prior to surgery, she underwent plasmapheresis. This is another way to try to treat or to control acquired von Willebrand, as well as other supportive measures. She only, the bleeding only resolved after ligation of the arteries during surgery. So the moment you took out the tumor, the acquired von Willebrand stopped. This is our diagnosis. As Dr. Rahaf nicely explained, there's no personal or family history of bleeding. And it has multiple mechanisms. In Wilms tumor, it's because of adsorption of von Willebrand on the tumor surface. When it is antibody-mediated or related to inhibitors, it might be better controlled with plasmapheresis, but always try to treat the underlying cause. This is, in general, the diagnosis of von Willebrand, and this is a very old booklet provided by WHO, and it's free of charge. You can find it on the internet. So this is how you diagnose multiple subtypes of von Willebrand, and you have to remember that acquired von Willebrand, you might not have a decrease in activity or factor, just a decreased ratio. So, and then you confirm by multimers. Another issue about, and you can detect inhibitors in acquired von Willebrand. However, it's very labor intensive and not a lot of labs do it by doing mixing studies and then measuring residual ristocetin and collagen binding, or in ELISA, and again, it's not adequately standardized. So a lot of these cases, you just speculate that there's an antibody, but you cannot prove it. So for our practice, a lot of the multimer analysis is a send-out test. We send to the States for multimers. We received a lot of reports from them saying that in pediatric patients, that there is loss of very high molecular weight multimers. Do not jump to conclusions. This is seen in acquired von Willebrand. However, it is most commonly seen in specimen mishandling. So it's shipping time, heat, delayed separation of the plasma, or problems in freezing, all can cause loss of very high molecular weight multimers. So be cautious about diagnosing an acquired von Willebrand disease in pediatric patients with no obvious cause. These patients probably require repeat multimer analysis. The ratio is very helpful, as I said, in diagnosing type 2 and acquired von Willebrand. Use the cutoff of 0.6, that's the most recommended cutoff. Newer assays, like Dr. Rahaf explained earlier, the von Willebrand factor binding to glycoprotein 1b, R, and M are more sensitive and may replace the classic ristocetin binding in the diagnosis of von Willebrand type 2 in the future. Do we still have time? Or? Okay. So this is actually how to approach a prolonged PTT and a normal PT. First of all, exclude heparin contamination. You can do, if you find a prolonged thrombin time, normal reptilase time, that's probably heparin contamination. Some labs actually provide hepzyme, which is a form of heparinase that degrades the heparin in the sample and gives you the actual PTT. You can start by immediate mixing. If there is immediate correction, think about intrinsic factors, deficiencies, factor 8, 9, and 11. If there is no bleeding, usually it's probably factor 12. If it corrects immediately, prolongs after incubation, think about factor 8 inhibitor, and that you can confirm with the Bethesda assay. Mixing studies with no correction and even prolonged before and after incubation, think about lupus anticoagulant. There are rarely inhibitors to other factors, 9, 11, and 12. And confirmation, screening for lupus is by DRVVT, and confirmation is by the hexagonal phase. If you have both are prolonged, please exclude clinical causes such as DIC, liver dysfunction, vitamin K deficiency or antagonist, or oral direct anticoagulants. If it immediately corrects, think about common pathway factor deficiencies, such as 2, 5, and 10. Also think about rare combined factor deficiencies, such as 5 and 7. Mixing studies, no correction, prolonged after incubation, suspect factor inhibitor, and if it corrects immediately and prolongs with incubation, you might think of a factor 5 inhibitor. Normal PTT and prolonged PT, stop and exclude vitamin K antagonists and liver dysfunction. If there is immediate correction after a mixing study, do a factor 7 assay, because this is probably 7 deficiency. If there's no correction and there's prolongation before and after, think about a factor 7 inhibitor. This is all I have, and if you have any questions, thank you.